RheumMates podcast. This is a podcast about rheumatology, and it stars me, Jack, and my friend Mike, and we try to make sense of the complicated world of rheumatology and musculoskeletal practice. Welcome back to RheumMates. This is session 2. Thank you to everybody that tuned in to session 1 and enjoyed that. We had about 150 listens. We'll talk a little bit about that in the show, but I won't delay us any further. So this time I talk again to Mike, who is a specialist rheumatology physio, and we discuss the early inflammatory arthritis audit, and they released a paper about some lessons that had been learned on some various different topics about rheumatoid arthritis and what happens to people in the first year after diagnosis. So we chat a little bit about that. We obviously tangented away onto our favourite subject of axial spondyloarthritis, and we related to that and how we can try to improve things overall. So I hope you enjoy that chat, which will be with you in a minute. Couple of things I want to let you know. I am completely rebuilding my website, so that should be live any minute once you get to listen to this recording. So head to rheumatology.physio and it should be there as soon as possible in all its new, lovely, pretty glory. There'll be lots of blogs and things for you to see on there. Do go and check that out if you don't mind. Different videos and CPD materials that I make alongside, obviously, this podcast. Do make sure you subscribe to the podcast in whichever podcast player you listen to. I am still awaiting, unfortunately, for it to load onto iTunes, but you can find it on Spotify and Castbox and all the Google podcast players that you can find, as well as you can listen to it again on my website. So have a look there and do subscribe. And if you think any of your colleagues or peers might be interested, then please do give them the link as well. But without further ado, let's crack on with discussing the early inflammatory arthritis audit. Hello, welcome back to RheumMates. My name is Jack March and I'm here again with Magic Mike Dare. I've decided I'm going to come up with either pop culture reference to you every time we record or some sort of pun, Mike. So I've got about 3 lined up already, and 2 of them got vetoed by my girlfriend. So that Magic Mike was the one that was allowed through this time. You happy with that?
Fair enough.
Brilliant. So we were just looking at the statistics for the first RheumMates recording. We had about 150 people tune in, so that's pretty good considering I haven't really marketed it other than one sort of tweet that I did. So hopefully if I get around to doing a bit more social media noise, then we'll get a few more listeners this time around. And you sent me this really long document which is the National Early Inflammatory Arthritis. What actually is it? It's like some it's an audit, yeah. So some information that gleaned from the lists that are created whenever someone gets added onto the audit. We can talk a little bit about how that works in a minute. But we'll have a bit of a chat about that. But otherwise, everything's still much the same for you in clinic at the moment. I know you're doing a lot of remote consultations.
Yeah, still mostly, I would say 95% virtual consults, so telephone consults, and if we need to see any joints or have a look at any movements or anything like that, then we switch to video. And if someone is fit and well and doesn't have too many comorbidities and they do need to come in, then we do have that option now of bringing them in for a face-to-face. So probably that's not going to change, I would imagine, for the next 4 to 6 weeks. So.
Yeah. Do you think it's something that your service will continue longer term as well? I think there's a lot of people found it very useful. I think rheumatology is one place that certainly can be very helpful.
Yeah, I think physio probably yes, and I guess your review appointments for rheumatology yes, but it's very difficult when patients are reporting swollen joints and bloods are normal and video consults not always the greatest quality. It's really hard to make good clinical decisions without actually having the joint in front of you or having a look at all the joints. So, I mean, I think a lot of consults will be replaced by virtual consults, but I think there's always going to be a good space in room for face-to-face exam.
Definitely, definitely. I remember I think I can't remember if it was an audit, but I forget where it was from, and I'll probably someone might be able to find the link for it. But it was an AxSpA audit from a number of years ago, and they showed how far people travelled for their appointments. And it was something like I think the audit was from somewhere like Bristol or Birmingham, and they sort of had an average traveling time of sort of 45 minutes. So I always think if you can cut that out, especially with rheumatology, you end up with a lot of appointments sometimes. So even if you can cut out one or two of those journeys, sometimes it can be very helpful, can't it? And I think what we're going to talk about today, the early arthritis audit, they talk about these yearly reviews, and I suspect that not the first one for sure, for the first yearly review after diagnosis, but certainly when people have been stable on disease modifiers or biologics, etc., for a longer period of time, then probably some of them can be replaced for virtual consults as well.
Yeah, I would say probably all of them, Jack. I think once you're stable and you've got low disease activity, there's no reason why you can't have virtual consults. I think the challenge comes in more with the new patients when you're trying to kind of get to the bottom of their complaints and actually determine if they are a rheumatology presentation or not. You need to examine them really.
Yeah, one thing that's impossible to do by webcam is look at people's nails. I don't know if you've tried to do that yet, but unless you've got the world's best webcam, you can't pick up pitting in nails via webcam.
Yeah, exactly. And I think even simple things like just feeling the synovium of the MCP joints or PIP joints, they may not necessarily look that swollen and angry on a webcam, but I'm sure a lot of the time, if you actually had a feel around, there would be some sponginess and tenderness and so forth. So, yeah.
Definitely. So let's talk about this audit, and I'll put a link into the comments attached to the podcast and the video. But it's a really interesting document, really. And I think one of the things that's really interesting about it is within rheumatology, obviously, we get these types of audits because of the drugs that people start, and they go on to these or get admitted into these sort of databases which are housed to try and work out some data that sort of matches to a lot of the patients, really. And obviously it's not like a randomized controlled trial. You can't necessarily determine any causation or anything, but you can get some really nice sort of correlating data, and definitely you get some really big numbers. So I think there was I think they've got about 8,000 patients on this particular database, although not all of them were included in what we're going to talk about today, because they were mostly looking at their first yearly review in this one. So it was just the people that got added within the 12 months.
Yeah.
But you can certainly get some really nice data. And I think certainly for us as physios, there's some really interesting things in here about, how long it took to get referred, and what happens when you get treated early as well. Because that's something I always talk about is really you're looking, when we're talking about people recognizing these types of conditions and referring to rheumatology, it's so they can get medically treated early. And this sort of clearly shows that when people are treated early, they do better. So it's really interesting. Have you actually been involved in getting patients onto these or anything like that in the past? I know I did years ago, but I haven't done it in a while.
You mean the audits or? So, I mean, the services that I work in at the moment don't offer early inflammatory arthritis clinics. Those services are run directly by the trust.
Fair enough.
Although we may be involved in getting the patient down the pathway and in front of the rheumatology consultant in the early inflammatory arthritis clinic, we don't physically run those clinics yet. I mean, there's no reason why we couldn't run those services in a community service in the future, but for the moment, I think most of those services sit with the trusts. Yeah, it's an interesting document. I think, I mean, you and I always have the gripe, though, don't we, that all these services, these early inflammatory arthritis services, are so heavily geared towards rheumatoid and rheumatoid-like presentations, and they do a massive disservice, I think, to the spondyloarthropathy patients, especially the axial spondyloarthropathy patients, because these patients don't have angry swollen joints and high CRPs. So they often don't meet the criteria for these EIA clinics, which I really think is something that, as a rheumatology fraternity, we really need to work on that and improve the service for the non-rheumatoid patients, really.
Definitely. I'm sure you're the same as me, that you're looking for if you get a spondylitis patient, you find a swollen joint so you can try and force them through an early arthritis clinic. I bet you've done that before, like I have.
Yeah, exactly. Or you can't just hope they're gonna pop up with the CRP of 30 or 40 so that you can squeeze them down at your arthritis clinic. But most of them, if unless you've seen them in a really angry stage, they're gonna have a CRP of 5 or 6, or if you're lucky, 12. And they're probably not going to meet the criteria for an EIA clinic. So it's difficult.
It's a real shame, isn't it? Because I read some of these findings and you think, actually, if I map that onto what my clinical experience is with spondylitis, I bet if they did the exact same thing for spondylitis patients, you'd probably see the same sort of numbers. Like they pretty much everybody got a reduced disease burden. About 50% of them were in remission at 12 months after diagnosis, which if you think about, if I think about people who I've sort of recognized early doors and said, I think you might have rheumatoid arthritis, they get really concerned about that because they like, especially if they've got a family history, their parent, like a mother who's got really disabling joint deformities and things. And then if I said to them, well, actually, we've picked it up quite early, so there's at least a 50% chance that you'll go into remission in a year's time. That's a really reassuring number, isn't it? I've sort of, that's something I've sort of reasonably well known for a number of years, but it still surprises me that it's that high. But it is they do treat them quite severely with medications, and it does work.
Yeah, I think this document was quite interesting for me in the sense that it really just made me kind of refresh my confidence in conventional DMARDs. You bet your bottom dollar that most of these patients are going to be on methotrexate and something else. So, methotrexate really does work for these early inflammatory arthritis patients, and half of them are going to be in remission in a year's time. And I'd probably put a large sum of money and say that the other half, or a significant portion of the other half, probably had low to moderate disease activity, which is probably a significant improvement from what they came in with. And I think the review said that only 15% of patients started targeted therapies or biological therapies in the first year. So people seem to do pretty well with the conventional DMARDs, which was just a nice refresher for me, really.
Yeah, it's really good, isn't it? Because I think certainly we see a lot of research about the biologics and these new sort of JAK inhibitors, which I think is very well named. But
some patents in there, Jack.
Yeah, exactly. I'm sure there must be some money coming my way. But I think one of the things we know is that, like you said, with methotrexate and things, the benefits of it within this population is so well known, they almost just don't bother researching it that much anymore. So you just see all these biologics research, and then if you look at like some of the comparative trials, then actually the biologics aren't really that much better than methotrexate overall. But what they do is they give you that other option when methotrexate doesn't work. So like you said, it's not many people that end up going on to that, well, especially in the first year, it's not that many people that end up going onto those drugs anyway. So like you said, it is really good. And I think, like you said, that goes along with almost everybody that they mentioned in here had an improvement in their disease activity score at 12 months. So pretty much everybody got better to a degree. So like you said, even people with severe disease probably got down into moderate or even mild. So I think somewhere was it said, I've lost the actual numbers now, but somewhere it said that the average improvement was quite significant. So it was double the minimal clinical importance difference, if that makes sense as a sentence. So it was twice as much as that. So the people were doing pretty well across the board, really.
Yeah, I think it was also interesting to see the variations around the country. And
Yeah,
if
definitely.
I recall correctly, I think London was actually one of the worst performers out of the country, in the sense that only 15% of patients in the study got an annual review in London boroughs. And there were other kind of big stats for me, in the sense that only 39% of patients at their reviews in London boroughs had cardiac risk factors assessed, and so forth. And interestingly, other areas of the country, like the Northwest and the Northeast, and especially the Midlands, which, if you think about Yorkshire, and Leeds in particular being a workhorse for rheumatology, they really performing quite well up there. So it was interesting to see the variation in the country, in really the EIA services and the performance they're providing for patients.
Yeah, I do find it fascinating, this, I suppose, the lack of standardization, isn't it? Considering there is this good evidence all over the place for, if you do specific things, you get better outcomes, that there is these differences. And I wonder whether, part of me wonders whether it's a sort of a staffing difference, where you might have some people just not, like individuals almost, not performing within their departments so much, and it can bring down a different area quite significantly, because there's quite large areas, like you said, they're referring into sort of trusts, not in community care, so you might have quite a wide catchment area. But I think, like you just said as well, it is interesting for especially us as therapists, that sort of cardiovascular disease risk, but also bone health risk as well.
Yeah.
Those relatively low numbers that should be assessed every year. So one of the things that I always go on about on my courses is that it's worth doing those risk factors with your patients if you've got them in, because you will find a remarkable number of people that do need to go on to bone protection, or do need to go for further cardiovascular testing, and you can make a huge difference. It's something relatively simple to do, but can be a really big difference to the patient as well.
Yeah, I mean, it's preventative medicine, isn't it, really? Because we know that these patients with inflammatory arthritis, especially the ones who've had their inflammation kind of going untreated for a long time, are at a higher risk for cardiovascular disease, hypertension, dyslipidemia, diabetes, and obviously, osteopenia, osteoporosis. So it's definitely worth checking. I guess the challenge is always, like any NHS-based services, is when you're running busy clinics and you've only got 15 or 20 minutes per patient, and you've got a clinic list of 20 or 30 patients. I guess it's quite easy to just let a blood pressure or kind of a FRAX score slide, isn't it? So
yeah, it is. It is difficult, and I've worked in those clinics as well, and you are under a lot of pressure, especially with an admin burden, and those things do add another admin burden to you. But it is, it's always something I think is worth doing if you can manage it, and if you're seeing the person for a follow up, then maybe it's worth putting in the notes to do the next appointment, something like that, where you might just have a little bit more time. But yeah, definitely difficult.
Yeah, but I think overall it's a very interesting audit paper, and I believe there was a precursor to this audit paper, where they provided an actual breakdown of how many patients that were kind of seen in the early inflammatory arthritis clinic actually had inflammatory arthritis. And I mean, don't quote me on the numbers, but I think it was only about 37% actually had inflammatory arthritis, which means that 60% of patients that are coming into those clinics have mechanical or chronic pain syndromes. And I guess the main kind of thinking point for me is, is if some boroughs, some areas in the country are performing quite badly in getting people into these clinics in 6 weeks and getting them on treatment, is how do we keep all of those patients out of inflammatory clinics? And I think the numbers would really improve, wouldn't it? And I think that's really where we can make the big difference for our non-rheumatoid patients, like our AxSpA patients and our psoriatic arthritis patients, is if we take away that significant mechanical and chronic pain syndrome cohort out of inflammatory arthritis clinics, we could really make a big difference for our other rheumatic disease patients.
Definitely. And there was it's a good time to bring this up, really, but the NAS have just started a new sort of project where they're going to aim to bring the delay to diagnosis for AxSpA patients down. And one of their problems that they've sort of suggested is an issue is people not being aware of the signs and symptoms of something like an axial spondyloarthritis. And it works both ways, doesn't it? So if you've got a really long delay to diagnosis, it's probably because there's multiple things happening. So those patients, some patients are being missed and not referred. Some patients are being inappropriately referred, who should never have gone near a rheumatology department, because whoever's seen them's gone, I don't know what this is. Maybe it's an AxSpA because they've got spine pain and multiple joint pains or something. And then you've got the other people who who have been referred, but because those other people are, for want of a better term, blocking the referral, they're slowing the waiting list down for those people that do need to be there. So awareness is the first thing, isn't it? That we need to get people making better referrals. And like you said, you don't want to lose those 37% that are in there now, but you want to get that much higher. And there's always going to be some patients in there that are, they're musculoskeletal masqueraders for a start. So you're going to get some patients in there who just don't have it, but look for all the world like it. And you'll always get some that are delayed, but trying to, on average, bring that down. I think NAS's target is for the average was 8.5 years. They're aiming to bring it down to 1, which is a huge improvement. And I think, like you said, I think if you had an equivalent early arthritis pathway for the spine patients, those that could go a long way, where they were given sort of protected slots that could go. But then obviously you've only got so many rheumatology appointments in a year. You've got to kick something out, and like you said, that's the way to do it, is get some of those mechanical patients or persistent pain patients out of rheumatology, so that those ones that need to be there can be.
Yeah, absolutely. And I think the responsibility for that is very multifactorial, Jack. I think the responsibility lies with the referrer to make sure that they making good clinical decisions when they refer patients. I guess the responsibility also lies with the public to know more about axial spondyloarthritis and inflammatory arthritis. So to make themselves known to their GP when they do have swollen joints or, insidious onset of back pain at a very young age. And also the responsibility lies with the trusts in kind of rheumatology services to, make fast track pathways for inflammatory back pain, for example, available and accessible like they do for early inflammatory arthritis. I think if you look back at the review documents from the all parliamentary review that NAS were involved in, I think less than 40% of trusts had early inflammatory back pain pathways. So it's really something that needs to come up higher on rheumatology departments' agendas, especially because, conventional DMARDs don't work for AxSpA patients. So the NHS is spending a truckload of money on expensive drugs for these patients. So, we need to improve the service for them. It's not like methotrexate or sulfasalazine that's relatively cheap and works well for peripheral arthritis, for example.
Yeah, it's a fascinating sort of conundrum, really, isn't it? Like you said, it's sort of, if you have someone who has an AxSpA develop and they don't attend the GP or the physio for 3 years, then obviously their delay to diagnosis is going to be significant. But then we can't say, we can't rely on someone Googling their symptoms and getting the right answer either. So, I know NAS do great work trying to get public campaigns out, but I think also it's got to be any healthcare professional that sees people has to be aware that those signs and symptoms could be, no matter how subtle, could be related to an AxSpA. And I think, again, I think that study that showed 8.5 years, I think was back in 2016 now, so it is a bit outdated, but I think they showed that the average person had seen about 6 healthcare professionals as well during the time of having being delayed. So you think there's 6 opportunities there where they could have been referred, and weren't, or whatever it was. And some will always slip through the net, but you've got to minimize that as much as possible. So I think from a professional responsibility, we need to be aware of these patients and make sure we screen them appropriately, know what the pathways are, whether they're appropriate or not. We still need to know what they are, and then move forwards. Like I had a patient, a colleague ring me the other week who the only way of accessing rheumatology where they are is they have to have had an anti-CCP done.
Right.
And you're like, well, that's not going to do much good for an AxSpA patient.
No.
So there's weird sort of things all over the place, but you've got to know sort of on location where or what the pathway is for that specific or potential diagnosis, I think, to try and help, because we do know there's a delay. So while it maybe shouldn't fall on us to do that, then unfortunately we have to do that to try and help these patients, really.
Yeah, and hopefully, and if we really sum up the review from my side, is there's great evidence in this review from BSR on early inflammatory arthritis services that the vast majority of patients are in a much better position 12 months after they enter the system, and half of the patients are in clinical remission, which is massive after 12 months. And I think the paper also highlights that there's really good evidence to show that the kind of associated condition risk is much lower when people are on treatment: cardiovascular risk, fracture risk, hospital admission risk. And I really hope that we can read papers in the future on AxSpA and see the same kind of numbers, where we see, significant number of AxSpA patients are seen quickly, and half of them are in remission in a year. And yeah, I look forward to reading those papers in the future for our AxSpA.
Sounds like your PhD, and you could be Dr. Dare, and you can sort that out.
Not for a while, I don't think. Not for a while. Maybe one day when I'm big, Jack.
No worries. Well, hopefully everybody does download this report and like we have, gained some really good information, but also be reassured that the patients that we're referring are going to do pretty well, and we can reassure them at the outset that they're likely to do pretty well, without going on to really what aren't very nice biologic drugs, really. And then hopefully as you said, we can use some of this to move forwards and improve referrals.
Yeah, exactly. And I think although there's a lot of numbers in here that need improving, I think overall it's very encouraging to read that there's a 50% chance that patient with several swollen joints sitting in front of you is going to be in remission in a year's time, which is really encouraging, I think.
Yeah, brilliant. Cool. Well, great to talk to you again, Mike, and we'll do this again soon. I'm sure we've got a couple of topics that have turned up on Twitter recently that I think we can get in for a conversation. So we'll do that next time, and I'll come up with a new pun around your name as well.
Thanks, Jack.
No worries. Have a good rest of the evening.
Cheers, Jack.
Bye.